Hi, this is Andrea Kane, and I'm here with HIT 330, Health Information Technology, and we are on Chapter 4, Health Record Content and Documentation. This is the second half of Week 8. And again, if you look at your syllabus, we are doing Unit Objectives 9.4.1 through 9.4.9 and 9.8.1 through 9.8.6 this week. So this is the second video that you will watch on this week. All right, so let's get into it and talk about it and see what we can learn. Documentation is the recording of pertinent healthcare findings, interventions, and responses to treatment as a business record. Okay, make note of that. It is a business record because that has to do a lot with the legality. And you'll be taking a course on that in the spring of your second year. But you need to understand that that healthcare documentation is a business record. It is also a form of communication among caregivers. It allows for the telling and retelling of events. And this is why people will say, if it wasn't documented, it didn't happen. Because if you don't document it, there's no way for you to go back and retell what happened because it wasn't documented at or near the time of event. That's another phrase I need you to put in your mind. At or near the time of the event. That's when healthcare documentation needs to take place legally. All right, so moving on. What are the impacts of poor documentation? Well, of course, there's poor outcomes. If you fail to document as a caregiver something about a patient's care, the next provider who takes care of that patient is not going to know about it. They may repeat it, they may double it. I mean, you think about medication errors. If somebody doesn't document a patient's allergy and somebody else gives them medication for that and it causes an allergic reaction, they can have anaphylactic shock. So it's very serious. Oftentimes where you see this happen with medications, it has to do with insulin. Somebody gives the wrong insulin dose, or they give insulin to a non-diabetic patient, or they fail to give insulin to a diabetic patient. Again, when you document, that helps everyone else who's caring for the patient know what's going on and can improve outcomes. And as I just went over in those couple of scenarios, there's issues with patient care. And those may, in fact, cause the patient to have a longer length of stay, have many, many, many more healthcare expenses. It can even cause damage to a patient. There are patients who have received treatments that have caused them to have strokes and have residual problems because of that. It may mean that the patient, when they try and go get the next level of patient care that they need, they're not able to do it because they don't have the documentation. An example of that would be if the doctor ordered an x-ray, a chest x-ray, before they could have a CT of the chest. Well, if somebody doesn't document that x-ray, the patient has to go back and get another one before they can move forward with the chest CT. So it does cause issues with patient's care and delays and frustration, rightfully so. Poor documentation also causes inaccurate diagnosis and procedure codes. And that is bad because as you go into the HIT field, you may end up being a coder or doing coding. And you are relying on the accuracy of the documentation of the healthcare provider to assign those diagnosis and procedure codes. So if you don't have accurate information from the provider, you're either going to have to query them, or the diagnosis or procedure codes that you assign are not going to be accurate or as specific as they could be if there were good documentation. Poor documentation then results in errors on healthcare claims. We put down things, we make educated guesses. Those are all not right. It needs to be in the documentation. So one of the things you will find as you go out into the HIT profession or HIM profession, used interchangeably of course, is that you will spend a lot of your time educating people about what is good documentation, what is appropriate documentation, what is legal documentation. So as you go through your courses, be keeping those things in mind. How you're going to educate, what you're going to educate, what do you need to know? And what do you do if you have poor documentation? How do you resolve it? And how do you do it without making enemies? Because the last thing providers want is somebody coming to sit beside them, or even worse, picking up the phone or shooting them an email and saying, hey, your documentation is poor, fix it. They're trying to care for patients. The last thing they want to do is listen to all of this. And so you have to find a winsome way to be able to communicate. You have to find a way to establish a positive relationship so that they understand where you're coming from and they can see how it benefits them as the provider as well as the patient. So keep those things in mind as you go through your classes. Documentation standards, oh my word, there are tons and tons and tons and tons and tons, and we will go over lots of them. We will touch on a few in this course, but we will go over thousands by the time you are finished. Well, okay, maybe not thousands, but it will definitely feel like thousands. But documentation standards are so that you can have people documenting the same way each time. It describes those principles, codes, beliefs, guidelines, and regulations that guide healthcare documentation. Think about it. We've been talking about all these different healthcare delivery settings. You will be talking about Joint Commission. I'm trying to really quick look back and see. Yes, we have talked about Joint Commission. We talked about accreditation. We have talked about conditions of participation. All of those have documentation guidelines, requirements, recommendations. There's state laws, federal laws. Then you have your organization's own policies and procedures, medical staff rules and regulations, and those types of things. Not to mention corporate compliance and all that brings into play. So you've got to develop the standards, and usually that is a document for your organization, and hopefully in this day and age there are organizations that have already developed that, and that's already out there and part of the training that they provide everyone who does healthcare documentation. But you'll need to know that and be able to help with that training if you are tapped to do that. Anyway, going on, it dictates how healthcare providers should document the treatment and services within the health record. That's exactly what it is. All right, so a standard is a set of principles, codes, beliefs, guidelines, regulations that have been vetted, meaning that they've been reviewed, they've been researched, they've been compared to what else is out there in the field, best practices, those types of things, and agreed upon by an individual or a group of individuals, meaning that they've come together and said, yes, this is what we all will do, or this is the commitment we're making as an individual or as a group. A documentation standard then is one that controls the health record and how you document in the health record, because not just anybody can document in the health record. Typically, HIM professionals do not ever document in the health record. We have documentation that ends up in the health record, but we do not document in the health record. An example might be for release of information back in the paper days, that we would be documenting things that we released, and we would include that, and it would be attached to the medical record. But it would not be considered part of the legal medical record that was documented by the direct caregivers. All right, so documentation standards and EHRs. Yes, you are using the same basic documentation standards, because think about it. It doesn't change whether you're on paper or you're electronic. The same things need to be documented. The cool thing about EHRs is that they use templates, and so you can make sure that everything's in there. But you would do that in a paper-based world through forms and forms control. So documentation standards have grown in complexity and detail over time. They focus on patient care quality, appropriate reimbursement, and prevention of fraud and abuse. They vary based on the type of health record. What standards you have for an ED visit will be different than what you have for an inpatient visit, which will be different than what you have for a labor and delivery visit, which will be different than what you have for an ambulatory surgery visit, or a home health visit, or a hospice record, or a long-term care record. They vary. Again, think about the regulations. Who's regulating, how they're regulating. the care setting itself and the care that the patient's receiving. Anytime patient's receiving care, it has to be documented, but what has to be documented, how it has to be documented, and why it has to be documented may be different. So that's why we go through this. There's a class that you will get next fall, and it is called Comparative Records. And that's what we do in that class. We look at all these different types of settings. We look at correctional facilities. We look at intermediate care facilities for the intellectually disabled. We look at mental health facilities and substance abuse facilities. We look at all of those and tear apart, okay, what are the documentation standards for that particular type of health record and health setting based on regulations, accreditation, and laws and all sorts of things. So you've got that coming up. This is just a touch on it and get you a little bit used to it so that when you hear it again, you're not like, oh, I don't think I ever heard that before. So that's really what it is here, is just to introduce it. There are multiple sources of documentation standards, and I kind of covered those. You can have insurance companies or payers that have requirements, regulatory agencies from the government, licensing boards, accreditation bodies, your own facility policies and procedures, and then of course your medical staff bylaws and medical staff rules and regs, all of those. The goals of the documentation standards are to ensure complete health record and a complete health record. You want to have a complete record. What does that mean? How do you define it? How do you know when a record is complete? And each organization has to define that. That has to be written so that everybody knows this is what a complete health record is, whether it's paper, whether it's electronic, whether it's a hybrid between the two. You have to be able to define that clearly. And then you have to put a timeliness on that. When is the record complete? When does it have to be complete by, and what do you do if it's not? And then it has to accurately reflect the treatment provided to the patient. Anything that was done to the patient has to be documented. So who's going back and making sure that that happens? Or what sort of edits do you have in your EHR that are looking for things to make sure that they get recorded? So for instance, many EHRs have their program to say, if this patient is inpatient status, I need an H&P. So if there's not an H&P, there's an alert that comes after 24 hours to whoever's listed as the attending physician to alert them to say, there's no H&P on this record, we need one. Same thing with a discharge summary. You can set that so that the day after discharge, if there's no discharge summary within 24 hours of discharge, that it goes back to the attending physician and it says, you need to do a discharge summary because there isn't one on the record. Same thing with a consultation. You can set up your system so that if a consultation order is placed through CPOE, that within 24 hours, there needs to be a consultation report on the record. And if there's not, then again, alert goes out. And this way it tracks, okay, this is what you ordered, and this is what we should have seen reflect the documentation of the treatment of the patient. And you can do that also for like nursing admission notes and all those types of things. You can set up alerts that those should be happening. Again, a screen you might have is if in the admission assessment, the nurse notes that the patient probably needs a dietitian consult, they can indicate that through the screen. It can send a notice to the dietitian. The dietitian can come and do that and provide their documentation. So the system knows that if someone has requested a dietitian consult, that it should be seeing within 24 hours some type of dietitian documentation. And if that's not there, then again, there can be an alert. And those can go to a supervisor or a manager, or they can go to whoever it's assigned to do. But that's one of the ways that you have to make sure that if there's treatment provided to the patient, there is documentation. And then, of course, it drives appropriate reimbursement through the accurate code capture. So, again, if you've got complete, timely, and accurate documentation, then you can have complete, timely, and accurate coding, which will help you have complete, timely, and accurate reimbursement. So that's really what you want to do. Medical staff bylaws are standards that govern the practice of the medical staff members. They are voted on by the organized medical staff and the medical staff executive committee. And these rarely change. I mean, medical staff bylaws change maybe once every 5 to 7 to 10 years. Unless if there's something major coming out of the government or a federal regulation, that's when a medical staff bylaw will change. Typically, those are set up, and then they are not adjusted very often. The medical rules and regs tend to get adjusted more often than the bylaws. And the bylaws, although they do have some documentation requirements in them, they really pretty much focus on the medical staff themselves. How do they get credentialed? How do they get privileged? What happens if you need to discipline a medical staff member? What kind of appeals process do you have for those? And of course, then they have to be approved by the healthcare organization's board of directors. And typically that's more of a rubber stamp approval. It does have to go to their committee, to their meeting, and they do have to approve it. And yes, they are sent out in case the board members want to read them. But in most organizations, if it made it through the organized medical staff and was approved, the board is not going to argue with it unless it's something that they know from a legal perspective is significantly wrong. It's used to enforce quality of care. Again, this goes back to quality of care, not so much documentation, although there are some documentation things in there that have to be, that are direct standards for documentation. But most of those documentation standards are then really amplified and gone into in major detail and include additional ones in the rules and regs. Medical staff bylaws are required by licensure, accreditation, and federal and state regulatory bodies. So yes, they are, anytime you have Joint Commission come in, anytime you have the state come in, they will be looking at the bylaws. Each organization then mandates content, which I talked about. Bylaws are not identical from facility to facility unless they're under the same health system, unless they're owned by the same health system. And then they do try and keep those pretty similar. Medical staff bylaws, oh, I just said that, sorry. All right, moving on. So physician and non-physician providers who have privileges to practice medicine in a particular healthcare organization are labeled medical staff. They may or may not be employed by the healthcare organization, and that's important to know. You may have non-employed independent physicians on the medical staff, and you may have employed physicians on the medical staff. You may also have retired physicians that have sort of a emeritus or retired status that have a few minor privileges, but they're not practicing medicine. So you may see that as well. They are subject to the medical staff bylaws. Everybody is. The medical staff bylaws will lay out who has active membership, who has associate membership, who has consultative privileges, who has courtesy membership, all those types of things. And what does that mean? And how does that guide their practice? How does it limit it? How does it open it up? Those types of things. And yes, I have seen many times medical staff bylaws, rules, and regs, and I have been involved in revising both. And I have been at meetings where those have been up for discussion, both at the medical staff executive committee level as well as the entire medical staff. So yes, exciting times. Okay, so privileges. They are specific services and procedures that the medical staff member is deemed qualified to perform at a particular healthcare organization. Okay, I want to go back. Credentialing is not the same as privileging, and we'll get into this later, but you need to know this now. Credentialing is different than privileging. Credentialing means you're verifying that this person can be a part of the medical staff. That's credentialing. Privileging means you give them the approval and permission that they can complete certain services and procedures based on their training, based on their specialty, based on all those things. So for instance, you can have a hospitalist who is credentialed and then privileged to do lumbar punctures. Okay, so they are credentialed to act as a hospitalist, but then they may be privileged to do lumbar punctures. Another example is you may have a ENT surgeon who is credentialed, and then they are privileged to perform plastic surgery procedures based on their education training and their their experience and their cases that they've done before and the cases that they currently do. So just keep in mind, credentialing and privileging are two different things, but they're done usually at the same time when someone starts on medical staff and every 2 years when they're recredentialed. But the privileging can take place at any point if a provider learns a new procedure that they wanted to start doing and they've gone through training, they've done cases, then they can get privileged at any time for that new procedure. Accreditation. We talked a little bit about this when we were going through Joint Commission, and that is a voluntary process. Talks about how we measure compliance with standards and differs by the type of program or service. So I'm not going to spend a lot of time on this since we've really kind of touched on it when we went through Joint Commission. And again, if you are accredited by an approved organization, and there's a list of them, then you don't get routine state surveys. If you choose not to go the accreditation route, then you will get a state survey. You will. Been there, done that, got the t-shirt. Okay, so accreditation organizations also must go through their own CMS review to make sure that their accrediting process is appropriate and that they are as strict as the government wants. And Joint Commission, we kind of covered Joint Commission before, so I'm not going to stop too long on this slide, but just make sure you know what that is and what they do and who they accredit. And then there are some others. State statutes, oh my. And this varies state to state. I have worked in healthcare organizations in Michigan, Florida, Indiana, North Carolina, and Iowa. So I've got 5 states worth of understanding of state statutes. And I will tell you they are all very different because they are written and approved and they're signed into law and they address the documentation requirements or expectations for that state. I will tell you, quite honestly, that I am very surprised at how minimal Iowa's statutes are compared to other states. I have been to very detailed states, and I have been to very general, non-specific, almost non-statute states, which is what I would call Iowa, in my opinion. But it would be interesting for you, if at some point you are interested, to take a look around at other state statutes just so that you're aware of some of the differences. But I will tell you that Iowa is shockingly minimal in their state statutes for healthcare as compared to the states around it. All right, so the legal health record, you again have to determine that for your organization. There are some things that you will be told have to be included, but exactly what is the legal health record is up to your organization. And it is the documents and data elements that your healthcare providers include in response to a legally permissible request for patient information. So, is everything in the medical record the legal health record? Yes and no. It is if you use it as the legal health record. It is not if you define it as not. So an example I had talked about, perhaps I think in the last video, was emails. Emails may be included in your medical record of your organization, but you may choose not to include them as in the legal health record that you release when requested. Because remember that you're talking, the medical record is a business record that is owned by the organization. The information in it belongs to the patient, but the record itself belongs to the organization. Remember, business record. So you can define as an organization what your legal health record is. And it may not be the same as quote unquote your medical record, which includes everything, every little tiny scrap of information. Again, you've got to have policies and procedures defining legal health record, and I would expect most places these days do. If they don't, that tells you a lot about your organization and should make you fear and should make you want to think about perhaps this is not the place for you to be, because in this day and age, that should have already been taken care of 10 years, 15 years ago. At the very least, 5 years ago. All right, general documentation guidelines. They apply to all categories of health records. Every healthcare organization should have policies, must have policies and procedures. And then the documentation needs to be organized systematically to facilitate data retrieval and compilation. And that's just what it says. You need to make sure that your medical record is organized so that people can find what they need, whether that's in paper form or whether that's electronic form. It needs to be organized logically and systematically. Only individuals authorized by the organization's policies should be allowed to enter documentation in the medical record. And I referred to this earlier. You can't just let anybody write in the medical record. There are different types of staff, like facilities, that are not allowed to document in the patient's health record. There's no reason for that. It's the caregivers themselves. Even if a caregiver is assisted by, say, someone from housekeeping or someone from HIM, the only individual that's authorized is that patient caregiver, and that's who should be documenting in the health record. Anything else needs to go like on an incident report or some document like that that is not part of the health record. Organizational policy or medical staff rules and regulations should specify who may receive and transcribe verbal physician orders. And I will tell you, these two things, every time I have been in a Joint Commission survey, we have had to produce these policies. Every single survey. They are that critical to all of this. Every time the feds have come in or the state have come in to do some type of survey or review, we also have to produce these. They are required. And when you think about it, it makes sense. You need someone who has been trained appropriately to receive and transcribe verbal physician orders. And that's not just anybody. You have to know the whole process. You have to know, okay, here's what, if I get, all right, first of all, who is allowed to receive and transcribe verbal orders? Then you have to know who's been trained. Then you have to know, okay, if I receive it, here's how I receive it. Here's how I write it down, because there are certain steps you have to follow when you write it down. Here's how I do a read back verify, because you have to read it back to the physician to make sure you got it right and have the physician verify, yes, that is the verbal order I'm giving you. And then it has to be put into the system correctly and timely. So there's a lot of pieces and parts that go with this, and that's why there is the requirement that you have to have a policy, and that is also in the medical staff rules and regs, who can, or bylaws sometimes, who can receive and transcribe verbal orders. So health record entries should be documented at or near the time of the event. Again, that is just standard. That is, no matter where you work or what you do, that is what should be happening. It needs to be documented at or near the time of event. Authors of the entries have to be clearly identified. And this is where electronic records really help, is that for the most part, if somebody signs in, their information is there. And once they do their entry, it captures that it's under that person. So that's why it's important to sign off your computer, sign back on, sign off, sign on if you're a healthcare provider who is doing documentation, is because it needs to make sure that it knows you are the author of that entry, and also that your entry is dated and timed and signed. And then only abbreviations and symbols approved by the organization or the medical staff rules and regs should be used in the health record. This is a never-ending, I should say, never-ending struggle for an HIM leader in an organization, because everybody likes to come up with their own abbreviations, and half of them nobody knows except the person using them. And how do you get your arms around that? And how do you audit for that? And how do you train for that? And how do you keep up your abbreviations list? Been there, done that, again, got the t-shirt multiple times. It is a big challenge, but it has to be done. And every time you are audited, reviewed, accredited, what have you, they're going to be looking at these 3 things as well. All entries in the health record should be permanent. This means no whiteout. If you're in a paper world, whiteout is evil. No whiteout. You can mark through something, write error, and put the correct information in, and then date, time, and sign it. You can do a late entry and note it as late entry and put in the entry, date it, time it, and sign it as to when you put the late entry in. Those are all fine. You cannot erase. You cannot obliterate. You cannot destroy. And this is why we talk about versions in the EHR, the electronic health record, is because you've got to keep each and every version so that you can see what changes were made, when they were made, who made them, and what was changed. And so, let's see, it goes on to talk about corrections or information should be inserted as an addendum. That is, notice here, by the patient. Anything that's added to or corrected to the record by the patient needs to be an addendum. Again, the patient never changes original entries in the record. They can add information to it. And here's what is most usually often done or recommended to be done. And that is, if a patient disagrees with something in their record, let's say a patient came into the ED and the ED provider documented that the patient appeared to be intoxicated. And for whatever reason, the patient didn't feel they were intoxicated, and a blood alcohol was not done to prove whether they weren't intoxicated, but the patient feels that that information needs to be removed from their record. They can't remove it from the record. But what they can do is submit a letter or a document stating, I disagree with this, and here's why, and this is what I want removed, and date it, time it, and sign it. And that gets scanned into the record so that it's always there as a record, a piece of the record itself to say, according to the patient, they dispute this. Now, typically when there's a request for a correction, it goes to the provider. And the provider is the one who documented it, is the only one who can make the change. So let's say in that scenario I just gave you, the patient comes in, they're upset. This was written about me. I disagree with it. I want it changed. I want it removed from my record. The first thing we do is have the patient fill out a request for amendment. And in that request for amendment, they explain, I don't like this. I want it removed. Here's why. And they date, time, and sign it. Then it goes to the provider who did the original entry. And we say, we've got a request for amendment. It's from the patient. Here's what it's about. Will you review the record and determine whether or not you will make the amendment? The provider then goes back in and they say, you know what? I didn't do a blood alcohol. I'm going to go ahead and remove this. Or maybe the provider says, yes, but that was my... I wrote that they appear to be intoxicated because they were having a difficult time controlling themselves. They were unable to walk a straight line. They were very loud. They were very combative, and all these other things that were documented in addition to the appears to be intoxicated. And so the provider may say, no, I refuse to amend this record, and here's why. And then they sign off on the request for amendment form, and then we notify the patient. The patient can still submit documentation to say, I disagree with this, and we'll keep it as part of their permanent medical record, but we don't amend the original. And in that same scenario, let's say the provider did decide, oh, well, I can pull that information off. So then that's when the provider would go in and make an addendum in an electronic world and say, this phrase needs to be removed and here's why, and then date, time, and sign it. And then we would notify the patient, yes, excuse me, the doctor agreed that that needed to be amended and has made the amendment. So either way, you want to keep all the information. You don't have anybody tampering with the original entry. In an EHR world, they do an addendum, or they amend and create another version of the document, but you still have both documents. In a paper world, they can correct it on paper, but they have to indicate that they're correcting it, and the original entry still has to be visible. So for instance, they can't white it out, they can't black it out, they have to just draw a single black line through it so it's still visible and able to be read, still legible, and then they can make their correction. So I know I went on a long time about that, but that's something that you really need to know now and keep in mind, because we'll be coming back to that again. CMS documentation requirements. This needs to be imprinted on your brain. Memorize, 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 because you will come back to this over and over and over again in this program. So the entries have to be legible, complete, dated and timed, author identified, and authenticated, meaning signed off in written or electronic form. All right, and this goes through what authentication is. I once had an issue in a nursing home with a physician that says, why do I need to authenticate my entries? You know who I am. And yes, we knew who he was, but this is a requirement. It has to be authenticated. Every entry, whether you're a nurse, an aide, or a physician, a dietitian, somebody in one of the therapies, you have to have your entry authenticated. And so this goes on, and note that CMS requires controls to prevent any changes after the entries have been authenticated. And what this means is once it's been authenticated, then you have to either do a new version of it, an updated version where you keep both, or you need to do the addendum type of amendment. Auto authentication is when you have a physician or other care provider who authenticates an entry without reviewing it. Oh, this is bad, 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 bad. But we have a lot of physicians that do this. And it's really, in my opinion, a bit of laziness. A lot of times you'll see this happen with dictation. They'll dictate a report, they'll have it transcribed, and then they'll just authenticate it without reviewing it. There may be gaps, there may be incorrect lefts and rights, there may be all sorts of things, and they'll just click on it and they'll have a sentence that appears that says authenticated without review, as if that somehow gives them a pass that the poor content or the poor documentation in their report is somehow passed by and is okay, rubber stamped, because they authenticated it. I will tell you from a legal perspective, having sat in on a couple of malpractice cases back in the day, that this does not go over well with a judge or jury. A physician does not impress a judge or jury in a malpractice case when they've got a report that basically indicates they authenticated it, but they didn't review it, they didn't edit it, they didn't do anything to it. It shows it implies sloppiness. And if someone is sloppy with their documentation, it raises the question, are you sloppy with the medical care you provide? Are you sloppy with the surgical procedure you perform? And a lot of physicians, a lot of providers don't get this, that their documentation is a direct reflection about the care that they provide, or the surgical services they provide. You can't be an excellent surgeon and slop through your documentation and not get away with it. Sooner or later, in this litigious world we live in, where malpractice cases are fairly common and settlements outside of those cases so that they don't get to a jury or a judge are common, it's expensive. And this is one way a provider can protect themselves is by making sure their documentation reflects the good care that they've provided. So sorry to get on my soapbox there, but that is one of the ways that you can work with providers who have that sort of slop through my documentation attitude to get on to patient care. They go hand in glove. And there's nothing worse for a provider to sit there beside their lawyer in a courtroom and have their documentation blown up to the size of a video screen showing just how inattentive, let's be nice and say, they are to their documentation. It's not good. And I'm sure it was very embarrassing for the physicians that I saw that happen to. So documentation, it varies by setting, but there's pretty much two types that you will see in the record. There's clinical and administrative, and they are exactly what they sound like. Clinical has to do with hands-on patient care. Administrative has to do with everything else. You have to have a health record for each person and for each visit. So make sure you understand this, that not only do they each person have to have a health record, but every time they encounter any kind of healthcare setting, there has to be documentation for that encounter. So you've got to have a record for each person, but you also have to document every single encounter they have. The content will vary by setting, and it will always contain clinical and administrative data. Inpatient health records, patient stays overnight, can be medical or surgical or obstetrical or, there's different ones that can be mental health. It is the most complex health record and obviously the biggest because it has so many different aspects to it. Now, the only one that I would argue is bigger than an inpatient health record is a long-term care record, because most hospital stays are 3 to 5 to 7 days now, and most long-term care stays are 3 to 6 to 9 weeks. So it really, you have to keep that in mind. Medical history, these are the components of medical history, and you really need to, again, memorize these, make sure that you know these. Take a look in your book if you want to go for more detail. They are pretty much what they sound like. Current condition. Why are you here? Why are you seeking medical attention? What's going on? What is your past medical history? Does it have any possible link to what you're dealing with now? Or is there something from your past medical history we need to know about as we treat you now to avoid it happening again? Personal history. This has to do with things that are part of your personal history that may have an impact on your health care. It used to be called social history. For instance, do you use alcohol or drugs? Do you, well, I won't get into the rest of that, but you can pretty much strike out personal history and think mentally social history, things that you do socially that may have an impact on your medical situation. Family history. Do your parents or brothers or sisters or grandparents have any kinds of conditions that may have a genetic or hereditary factor that the provider needs to be aware of that may be in play here? And then chief complaint. In your own words, chief complaint is in the patient's own words, what is wrong? Why are you here? So for instance, a chief complaint would be chest pain. My chest hurts. A chief complaint could be, I fell and scraped my arm. Another chief complaint could be, I don't know. I've run out of ideas momentarily. It hurts when I breathe. That's another chief complaint. Shortness of breath and chest pain. It hurts when I breathe. So chief complaint is what's wrong with the patient in their own words. Physical exam is the physician assessing the patient. And that's not, the physical exam is not the same as the medical history, and you will sometimes find providers who want to make it the same thing so they can ease their documentation burden. And sometimes they will mix it up by putting physical exam elements in the medical history. Oh, those creative people. All right, so physical exam, that's where they start, and they go through review of systems. You'll hear about that, review of systems, where they're going through the different body systems to see what's going on. They may also choose to just do a physical exam. For instance, if I come in and I complain that my wrist hurts, they may not examine anything except my wrist, because that's what I'm saying is wrong with me. And if my vital signs don't indicate that there's something wrong, then they probably won't do a physical exam other than to look at my arm or my wrist. Diagnostic and therapeutic orders, they are physician orders, and they can also be standing orders or an order set where based on your principal diagnosis or the diagnosis that you have, you may have an order set. So let's say someone has a congestive heart failure exacerbation and they come into the hospital. They may pull the order set for CHF exacerbation, and it has a list of orders that are based on national best practices, and they implement those based on the fact that you're having this exacerbation of CHF. And so they use those on every patient that comes in with CHF. Now it is up to the physician to review those standing orders and say if there's any they don't want used. That maybe in a certain case a patient should not have one of the orders used. It's up to the physician to review that and make that change. But otherwise the standing order set would be used if that's what the doctor orders. But they can also do individual orders. Clinical observations include progress notes, the integrated health record, which is, all the different others that are involved in the record, and then a summary statement if there's a death. There has to be a sort of a pronouncement of death if someone passes away in a hospital inpatient setting, where they indicate the date, time, means of death, and all those types of things. And that's usually the physician that's there that pronounces the patient. And then a care plan. Every patient has to have a care plan. You don't just bring them in and say, oh, it's nice to have you here. What shall we do? You have to have a care plan, and it has to be based on the patient's individual's personalized needs. So for instance, just because you have 3 patients who come in with congestive heart failure exacerbations does not necessarily mean they will have the same care plan. You may start out that way, but if you have someone who has congestive heart failure and they have cor pulmonale, you're going to treat them very differently than someone who just has congestive heart failure. And again, if you have somebody with congestive heart failure who also is struggling with cardiomyopathy, you're going to treat them a little bit differently. And if you have somebody else who has CHF exacerbation and they also have pneumonia, again, they're going to have a different care plan. The core elements of the CHF care plan may be in there, but each patient is going to have something a little bit different that addresses whatever else they have going on with them. Also, if someone dies, I'm gonna back up for a second. Autopsy reports are pretty rare these days. Most patients are either medical examiner's cases, or if an autopsy is going to be done, the body is sent to a major teaching center for an autopsy. It's pretty rare that community hospitals do autopsies anymore. It used to be that the pathologist, back in the day, the pathologist would come down from the lab and they would do the autopsies. And I suppose that can still happen, but it's just so much rarer. You typically get an autopsy report. It may even take 3 to 4 days after the autopsy before you get the report, because they're waiting on tests and all sorts of other information to come back that becomes part of that autopsy report. If you do have a patient that is sent out for autopsy, you will get a copy of that report, and you do need to make it part of the inpatient record. But again, it's pretty rare these days. And sometimes the medical examiner will send back a copy of their autopsy report that you can add to the record. Other times they will not. And if it's a medical examiner's case, Patient family members who want a copy of that have to go to the medical examiner. They have to go through the county to get a copy of that. So just be careful on autopsy reports. I understand why they have it in here because they have to talk about it, but it's so rare and it's very much an unusual situation. Vital sign. I mean, despite what you see on TV, despite what you see on TV, is nowhere near as common as it was. All right, vital signs. That's definitely part of an inpatient record. Flow charts, temp, watching the temps, watching respiration, watching all those different things. And then flow charts for our sort of like medication administration records, IV records where you're watching what is being given for the IV and how often and when it's changed and all of that. Diagnostic and therapeutic procedure reports are, of course, part of the record. That includes lab, path, radiology, other tests and treatments. And then, of course, you have anything surgery-related, anesthesia, operative, recovery room, also called PACU, post-anesthesia recovery area or unit, pathology, consultation. Those are other ones you may see. A discharge summary is required for hospitalizations greater than 48 hours. I would venture to say that it is very foolish not to require a discharge summary in this day and age on every inpatient encounter, even if it's less than 48 hours and even if it's an uncomplicated delivery or newborn. It is just, in this day and age, with continuum of care, with the information that has to be documented and verified for coding, compliance, reimbursement, billing, not to mention follow-up patient care, it is a very bad idea for organizations not to require a discharge summary on all inpatient records. But I know that because it's not a federal standard or a federal mandate, that many organizations try and shirk out of it by not requiring it, and I just think that's very poor practice. That's my personal opinion. So just take that with a grain of salt because that's just my experience and my personal opinion. But according to the rules that you're supposed to know for your test and for the RHIT exam, it's not required for hospitalizations less than 48 hours or uncomplicated deliveries or newborn stays. That's another one I'd like to change. If I had a magic wand, that's another one I would change for the good of all. All right, patient instructions. You have to have patient discharge instructions, and then if the patient's transferred, there's a whole bunch of stuff you have to have with that. Patient registration includes demographic information. That's all the patient identification as well as insurance information. And then, of course, it depends on the type of services provided, but you may have additional record requirements. So like with obstetric records, they typically have prenatal records, the labor and delivery records, and then with a newborn, they definitely have an APGAR form. And then ambulatory health records, they have demographics and they have a problem list. And usually I think it's within 3 visits you have to have the problem list. Ambulatory surgery records are very similar to inpatient surgery health records because pretty much you go through the same process. You prepare for the procedure, you have the procedure, you recover from the procedure a little bit, and then you go home. So it's pretty much the same. The only difference versus a hospital inpatient surgical record is what happens after you leave the PACU unit or recovery unit. That all becomes part of that inpatient nursing follow-up and record care. Tests and procedures are always included when you have your ancillary department visits, like lab-only visits or x-ray only visits, or I'm sorry, I should say radiology only visits, or you have like respiratory therapy, you go in for a pulmonary function test. So that's really pretty much just an order and the consent and the procedure report and any prep notes, if there are any, for more complicated treatments. a physician office record. It's preventative care, and then whatever illnesses and injuries that are addressed at the physician office setting. Long-term care, they have a lot of ongoing assessments. They have to assess patients on a regular basis as well as have a care plan. And we will cover the MDS and the resident assessment stuff when we get to comparative records. So this just introduces it here, and then we'll really get into it once we get into that. Rehab, they have a minimum data set, which is an MDS as well, and then they have their assessment instrument. And again, when we cover rehab and comparative records next fall, we'll get into it. But if you're interested, go ahead and Google it now, just if you're interested, or it should be at least touched on in your book. Behavioral health and substance abuse have very similar content, although they also include family and caregiver input. Home health, you definitely have a treatment plan and a health assessment, a problem list, treatment goals, interventions, and outcomes. And then federal and state initiatives on documentation. The trends really are to focus on quality of care provided and value-based care. And then reimbursement provides incentives for the quality of care. But of course, that quality of care, how is it determined? Documentation. How can you provide quality of care if it's not documented, or not documented thoroughly, properly, timely? So you can see if reimbursement is providing incentives or based on quality of care, that quality of care can only be proven by documentation. And then there's something called MACRA, and we will get into that. I'm not going to touch too much on it here, but again, you'll touch on it in the future. And it's the newest way that physicians are paid. Again, it's looking at incentivizing quality of care, and it requires a lot in terms of documentation. Core measures, we'll talk about those as you go through the HIT program. They're just introduced here because the government is focusing on those. So the government is focusing on quality of care provided, making sure it's value-based. They have programs like MACRA, and they use core measures to assess that. And then they provide incentives. So that's what you really need to know. And again, how are you going to say that your quality of care is what the government's looking for and that you're providing value-based care unless you can show that you are doing it through documentation? Paper health record format, there is something called a source-oriented health record, and that is different than a problem-oriented medical record, which is different than an integrated health record, which is different than universal chart order. So I'm going to point you back to your book to look at the differences on those, and I'm going to skim right by. Electronic record, point of care documentation is really a part of that, and then it's captured electronically. Web-based document imaging, you're capturing, digitizing, integrating, storing, and retrieving paper-based health record documentation. That's what document imaging is. You're scanning it, and then you're able to use it electronically. And it organizes and assembles the paper-based health record and controls the versioning, access, and search capabilities. So there's a lot of advantages there to document imaging. But you hope that you can move out of Let me back up really quick. Typically, you go from paper-based records to document imaging to an electronic health record. Those are really the 3 steps that you go through, and the document imaging is a middle piece. But sometimes with an EHR, if the system goes down and you have downtime, you have to revert back to paper, and you use document imaging to scan those papers and put them into the electronic health record. It doesn't work quite the same as the EHR where you're direct entering the information electronically, but it's there to make the record electronic. And yes, we will go over that many, many more times before you are done with the program. So what is the role of healthcare professionals in documentation? You have physicians. Physicians must document appropriately. They are the biggest ones that you will have to work with. And not just physicians, but you will have PAs, physician assistants, and nurse practitioners, as well as nurses and others. But physicians and their extenders, so to speak, or their mid-levels, which are the PAs and nurse practitioners, Those are the ones that you're really going to focus on. And then nurses, okay, that varies, but it's really important, their role in documentation. Allied health professionals, this includes your radiologist, not radiologist, but your radiology department, your lab department, your rehab departments that have PT, OT, speech language pathology. It includes dietitians, anyone who's going to be documenting treatment and the patient's response. Those all are part of healthcare documentation, and they are ones that you need to help and train and support. HIM plays a vital role in the governance of health information and in documentation. We are the last and greatest ones to fight for good documentation, to help define it, to help train people on it. We are the ones out there advocating for patients and for the organization to make sure that it's managed appropriately, its content is all that it should be, that it's protected, that it's released appropriately, that it is maintained, that it is available, but not when it shouldn't be. We're there to do all of those things. So we play a very important role. People look to us to know the standards and be able to articulate how that plays out for them. There can be other roles such as clinical documentation integrity coordinators and analysts. And that is it. And I'm sorry this took a whole hour to get through, but hopefully you got some good information out of it. Looks like we're going to have a couple of really good days this week, and then it's going to turn cold. So stay warm, and I will talk to you again soon. When I come back next time, we will be on week 9, looking at chapters 6 and 7. So take care, and have a great week.